Welcome back to the Gary Sutton Show on WSBA. We're with Dr. David Hogberg this morning, who I have never actually met in person, but now we can say we've met in person. And
well, you're even more impressive in person than on the radio, Gary.
Please. I'll give you that $10, I promise you later, Dave. Dave is with the National Association for Public Policy Research, but he's kind of the guy that keeps his eye on what's going on as far as medical stuff and a lot of other things, too. But, David, I've been looking at the Medicare bill. We just had the other night a little work here done in the Senate. 92-8, they voted on Tuesday night to send this Medicare bill. Reimburses doctors for treating more than 50 million elderly people and reshapes how we're going to do that. Tell us a little bit about it.
Well, the reason it was so popular and passed with such overwhelming margins in both the House and the Senate is because it got rid of what's known as a sustainable growth rate, which is this system that was really unworkable in Medicare. It was supposed to cut physician fees. Congress has suspended those cuts like 17 times since 2003. It's been a perennial headache. I also think it's not good for patients and physicians, so I'm glad that is gone. Unfortunately, for some reason, they put these new payment methods into Medicare in this bill that I think are likely to harm the sickest patients. The biggest one is called the the Merit-Based Incentive Payment System, MIPS for short. And basically what it's going to do, it's going to give doctors either bonuses or penalties on their Medicare fees.
By the way, I've noticed the longer the title, the more someone gets screwed. Is there some correlation there? Have you ever noticed that?
I wouldn't be surprised.
Yeah.
I've also noticed the more bipartisan a bill it is, the more likely it is someone is to
the more people will get that.
But like I said, it is going to give doctors either bonuses or penalties on their Medicare fees depending on how well they do on certain metrics. Here's two of the metrics that I think are most important for this discussion. One is how well a physician's patients score on quality measures, whether it be something like your blood pressure score, your blood sugar level, which is important for diabetics, and so on. The second one is the number of resources that a physician uses to treat his patients.
Right.
So, for example, a doctor who's his patients have good quality scores and he uses fewer resources is more likely to get a bonus under MIPS. Doctors who don't do that are more likely to be penalized. Seems like a way to promote quality. At least that's what they're claiming. But when you start to think about it, you kind of see what incentives this sets up for doctors, and it's not particularly good ones. First of all, you're going to have an incentive to try to avoid sicker patients and try to, load up your caseload with, folks that are relatively healthy, maybe moderately ill. The reason is those patients are going to be most likely to score well on those quality measures, and it's going to take far fewer resources to treat them. So,
in short, doctors aren't going to want to treat the sickest patients.
Yeah.
Because you want to get a good score.
That's right. I mean, if you have a caseload with lots of sick patients, they're probably not going to score well on the quality measures. You're going to have to use lots of resources to treat them, and hence you're going to have an incentive to not treat the sickest patients. And these are the patients that most need to see a physician, obviously.
Acutely and at the moment.
Presumably the people that Medicare is most supposed to serve, I think one could argue. And, what has this bipartisan bill done? Well, it's created this new incentive in there where the sickest people are going to suffer. And I think unless doctors really come to hate this system, it's going to be very, very hard to overturn. Why? Because, the sickest Medicare patients, the people who get, really ill each year, not that many, that they don't amount to much at the ballot box when it comes voting time. Second, because they're sick, they're not going to meetings, organizing, and doing the sorts of things that can result in Congress making changes to policy. Doctors groups, however, are organized, and if they really hate this policy, maybe it will be overturned. But I think, just like the sustainable growth rate, it could take years, and goodness knows how many sick patients, Medicare patients, will suffer in the meantime.
So have we, in essence, and I know some of the people out there who don't like to hear this, have we started to create a mini death panel? We get back to that whole thing again. Is it that drastic?
Well, certainly we have come up with a policy here that you would expect to see out of the death panel. The death panel, of course, is Sarah Palin's description, fairly accurate,
right.
I think, for the Independent Payment Advisory Board, which was created by Obamacare to cut Medicare's fees whenever Medicare reimbursements grew too quickly. Thankfully, thanks to Sarah Palin, IPAB has been so unpopular it has not even got off the ground.
Right.
Unfortunately,
have they even gotten any members to it yet?
Nope. President Obama, so far Medicare has not grown so fast that, IPAB is, you might say, needed. I think Obama is just hoping he can run out the clock and let it be someone else's headache, after he's gone in 2017. Mm-hmm. That said, MIPS, I think, is the type of proposal you would see out of an IPAB, because, one of the concerns I think Sarah Palin had when she called it a death panel is that the cost-cutting measures that IPAB would take would fall hardest on the sickest patients, and that's exactly kind of what you're seeing here with MIPS. I mean, it's encouraging. It cuts costs by encouraging physicians to use fewer resources, but that's going to probably fall on the sickest patients. So in that way, it's very much an IPAB-like policy.
I'm going to bring in a caller right now, John, who has a call for Dr. David Hogberg this morning. We call him David. Good morning, John. How are you?
Well, good morning. I'm fine today. But Monday, I found myself in the ER room with some abdominal pain. And I believe what I had was the virus that's going around. But the doctor's in there while I was there, and after I get home and I'm able to research, they did a CT scan on me. Now, in the hospital, I because of the Affordable Care Act, my new insurance is a $4,000 deductible. So I'm paying for that CT scan. It's $1,400 that's going to come out of my pocket. And I'm reading here that radiologists say that x-rays could have been done to ascertain the same situation for $75 to $100, because I can look up on Highmark. Also, if it's not done in the hospital, if they could have said, you need one of these, I could have gone down the road 3 miles to another place and got it done for $500. I find that just throwing money at this entire system, and I'm not for Obamacare, but something has to change, and just giving more and more dollars is not going to change any of this.
John, let me get a reaction from David. David?
I'm sympathetic to everything you said, and getting treatment done in a hospital is oftentimes one of the most expensive places to get it done. It's hard to shop around for prices. I don't know exactly what the solution is to that, but other than to say, consumers need to be able to shop around. But obviously, when you're probably in the condition you were in, it makes it a little, it makes it tough.
You're kind of a captive audience at that point.
Yeah, when you're in the ER, it's not like when you go in to see your physician and he recommends a test. And I have seen physicians, of course. A guy comes in and said he wanted an X-ray or an MRI, and the doctor said, well, you probably just got some arthritis. Let's give it a cortisone shot, see what happens before we go into
come back next week.
Yeah, and an X-ray may not even show up. So, in ER situations, obviously you can't act like a consumer, but I suppose it's always possible that if we were to see more consumer behavior in medicine, then eventually patients would start demanding, when they're kind of in these situations where it's not, it's ER, it's not necessarily life and death, but you would have some way of comparing
once
prices.
Once you've ascertained that you're in a safer situation.
Well, maybe an app on the phone. We don't have a phone app yet, right, where you can click on your phone and say, oh, well, the ER is going to, cost me $1,400. Can I get this done somewhere else cheaper? But I think that's in part because, we don't have a lot of those things that you see elsewhere in the market, because healthcare system is really overrun by government regulation, and what that does is, of course, is impede innovation. It impedes having transparent prices and being able to compare them and all that. So I'm glad this caller chimed in here.
And, the biggest thing that I think we're talking about here, the ironic thing is it's the Affordable Care Act. We're supposed to have more choice, better prices. And what do we have right now? I mean, we have higher prices. He just talked about that a moment ago. The $4,000 deductibles, meaning for $4,000, you don't have insurance for all intents and purposes, right?
Sure. And, look, there was this was it was funny when conservatives were pushing health savings accounts, 12 years ago, and saying that, coupling these tax-free savings accounts with high deductible policies. We were excoriated for that because this means it exposes patients to too much out-of-pocket costs.
Right.
Well, we had in mind $1,000, $2,000 deductibles. It's ironic that Obamacare now, the exchanges have all the regulations and that insurance companies have to deal with, the cost of those regulations. The only way they can keep premiums reasonable, or one of the only ways, is to raise up the deductible $6,000 as far as it can go. Look, if someone wants a $6,000 deductible, fine, but you should probably have a $50 premium for that kind of a deductible,
exactly
not $150, not $200. And we never said, our side never said, force people into $6,000 deductibles or create regulations or situations or incentives where you have $6,000 deductibles. It should be the choice of the consumer. But what these regulations have done has reduced the choice.
Let me bring George in New York in with Dr. David Hogberg. George, you're on the Gary Sutton Show on WSBA. Go ahead, George. Your turn to make the call.
Hey, good morning, gentlemen. Hey,
morning.
Good topic here. I heard that last gentleman call about his issue in the hospital, and I'm going to tell you something. One of the reasons that there's not been any change in some of this is the tort. There's no tort reform in any of this, okay? If they wouldn't have done that MRI or whatever, what do you have, the CT scan, okay, and then later found out there was a problem, guess what? Then there's 10,000 lawyers out there going to sue you for millions of dollars because you misdiagnosed it. And their experts said you should have done this,
something else, George, that really came to mind there when John was calling is, and having been in the emergency room a few times, 3 words: sense of urgency.
Mm-hmm.
Okay. And again,
that's it.
Yeah, sense of urgency gets added. You're the visiting team at that particular point.
Sure.
Yeah, and I totally agree with your guest there that one of the problems I see with some of these publishing these numbers are, I recently had a kidney transplant, okay, down at Johns Hopkins, okay? Now, they take some higher risk people down there, and, if it's going to get to the point where the government says, hey, you've got a bad system over here, well, yeah, we take all, too many of your patients are dying or whatever, they're just, a lot of these hospitals say, well, we're not going to do that anymore. Like you said, we're only going to be dealing with people that are healthy, and that's all well and good. And I frankly don't think, $5,000-$6,000 is really that unreasonable for a deductible, to be honest with you. Okay, maybe it's a little high for some people.
Right.
But, if you're constantly running to the emergency room, okay, you're going to chew that up pretty quick. Okay?
Yeah.
If you have a problem, obviously you need to go to the emergency room.
You got it, George. Hey, let me get a reaction here from David on that. Thanks so much for your call.
I've had an individual policy with a $5,000 deductible. I didn't consider it unreasonable. I just think that, it's a matter of preference and choice, and people should have, all sorts of different options, because some people won't find $5,000 unreasonable. Some people will. Mm-hmm. And they should have more options than, the limited ones that the Obamacare exchanges are causing. As for tort reform, certainly I'm in favor of tort reform. Some of the states that have done it, like Texas, have seen doctors come back, to serving areas that were underserved because of tort reform, because of lawsuits. One thing I would just warn you about on that is that the CBO did an analysis on this a few years ago and said tort reform would probably save the healthcare system maybe around $50 billion over 10 years.
Right.
That's not nothing, but it's not a lot given how big the healthcare, our total healthcare sector is. I'm not saying don't do tort reform, of course not. I'm saying that you should. I just, and I'm not saying that the caller said this, but some people tend to think that tort reform would be the big thing to drive costs down. It would help. It's not the big thing. I think the big things are the employer-based tax exclusion, which for insurance insurance, for health insurance, which creates all sorts of distortions in the market. And I think increasingly Medicare and Medicaid's impact on the system, which also has all sorts of distortionary effects as well.
I'm going to jump to a break here, Dave. We'll come right back. I want to finish up talking a little bit about this new Medicare idea here on the Gary Sutton Show on WSBA. David Hogberg, our special guest this morning, live from the Phoenix Park Hotel right after this. Welcome back to the Gary Sutton Show on WSBA. We're talking with Dr. David Hogberg from the National Association of Public Policy Research, or National Center for Public Policy Research, excuse me. And he's also, we're talking about Medicare this morning. You know, before we get to something else here, David, one of the biggest worries is that this new merit-based incentive payment system, MIPS as you called it, is going to basically cut costs for others, but it would do so on the backs of the sickest. Is that right?
Yeah, that's exactly, I would say that's exactly it.
Yeah, and so very much like a death panel-like policy, and that was one of the words that you said in one of the articles I was reading. So you want to improve quality, you want to cut costs, but you're going to harm the sickest patient. I mean, why is it that it seems like the policies right now, particularly in Obamacare, particularly with Medicare, don't help us all? Isn't that kind of the idea that it's supposed to help all of us at some point in time, not one to the exclusion of the other?
Well, for folks that don't believe that much in markets and who believe that government can run these things better than markets can, I mean this is what you end up with, and they don't tend to think about the second or third effect outcomes or third or fourth level. Second or third level effects of these sorts of things. That is the unintended consequences of these sorts of things. And, look, there is no system that's going to be perfect for everyone. The question is, what's the best system that you can come up with that's going to do the best for most people? And that's, of course, it would be a market-based system.
But I think the other problem, too, and I think you've remarked about this, is the idea that we have an unaccountable group of people making these policies. There's no skin in the game. There's nothing that's going to come back on them when they make the policy. It's just simply they're moving numbers around. Again, there's faces and lives and histories to those numbers, not just numbers.
Oh, absolutely. I mean, that certainly would have been the case with IPAB, the death panel, and it's the case with this MIPS too, because it's going to be largely bureaucrats at the Centers for Medicare and Medicaid Services who will be making a lot of decisions about the metrics of MIPS and so forth. And look, if they make a mistake that costs people their lives, what happens? Well, most of these people are civil service. You can't fire them. I mean, they might get some criticism and some embarrassment. But look, I think it is really dangerous and stupid to take decisions and let them be made by people who pay very little, if any, cost for being wrong. I mean, the person who has the greatest incentive to get a decision right is the person who pays the biggest cost if it is wrong. And in the case of medicine, that is the patient. That is, generally speaking, where the decision should be made. It should be made by the patient.
Now, for people who want to learn more about this, you've written a brand new book, and it's called Medicare's Victims, How the U.S. Government's Largest Healthcare Program Harms Patients and Impairs Physicians. And in fact, John Goodman, who's the president of the Goodman Institute and the author of Priceless, Curing the Healthcare Crisis, one of the great books out there, gave you just an absolutely glowing look at this book. It is really a wonderful read. And where can people pre-order this whole thing?
Yeah, just go to Amazon.com, type in Medicare's Victims. It's you can pre-order the paperback, which is $14.99, the Kindle version, which is $6.99. What a bargain!
Yeah, there you go.
And
not that you're promoting it at all, right?
No, not at all. And it will be basically out on July the 6th, just before the 50th anniversary of LBJ signing Medicare into law.
We'll be talking about it more. David, thanks so much.